Now we proceed to Symposium 16 in Whole B, focusing on quality assurance in healthcare delivery, with insights into physician engagement, high reliability practices, and the Ministry of Health experience. It is my great pleasure to invite our chairpersons, Dr. Pradeep Kumarasinghe de Silva and Dr. S. Sridharan. Now I warmly invite our chairpersons to introduce the speakers and panelists for the session.
Good afternoon. Welcome to the session on Symposium 16, Quality Assurance in Healthcare Delivery. We have 3 lectures lined up for this session. The first one would be the physician engagement in quality improvement. The lecturer is Professor Christine Zone. She is from Canada and she is the Professor of Medicine, University of Toronto Medical Director in Toronto, Canada. And we can start.
Wonderful. Thank you so much for having me. It's a great pleasure and honor to be here. And I want to thank the chairpersons of the symposium as well as the organizing committee for including quality improvement in your busy program. It's my bias and view that quality improvement methodology has the potential to transform healthcare, and physicians are a critical part of that vision being realized. So I have no relevant disclosures to report. So by the end of this session, I hope to achieve these 3 learning objectives. First would be to describe the importance of quality improvement in healthcare. The second, to understand facilitators and barriers of successful quality improvement. And finally, to appreciate our roles as physicians in quality improvement. So just the first objective is around what exactly is quality improvement. And many of you may have heard of quality assurance, which is really a precursor to quality improvement. The key difference is quality assurance is quite retrospective in nature, and it deals with achieving certain standards. Whereas quality improvement is proactive and continuous in nature. You're always hoping to achieve improvements on top of each other and is heavily data-driven. The photo of the man in the middle of this slide is Edward Deming, who is an American industrial engineer and statistician who really pioneered some of the current methods that we use in quality improvement. He actually worked in the post-World War II era in Japan with many automotive companies such as Toyota and helped them develop what we now call the lean Toyota way, which is a philosophy of creating high-quality products with low defects, and really helped Toyota and other automotive industries become successful. And the quality improvement in healthcare journey was very similar. We learned from this industrial improvement, and it starts with deep understanding of the systems, the healthcare systems in which we work, and the problems in which we find currently in healthcare. And then through that understanding, deep understanding of our systems, we seek to improve processes. And by improving processes, we therefore have an impact on improving outcomes for patients as well as healthcare workers. And following quality improvement movement about 30 years ago was the birth or really catalyst for patient safety. It started in the US with the Institute of Medicine report in 1991 that quantified and characterized patient safety events in hospital settings, where we learned and understood that over 100,000 patients in the US die of hospital preventable deaths per year. And this is not due to the disease that they came in with. This is due to treatments that they received in the hospital, which were viewed to be preventable. And the analogy that was given in this report was that the equivalent of one jumbo jet per day was crashing and killing all passengers on board. And if that was a reality, there would be immediate response and action taken to prevent something like that happening. And that should be the approach that we would take in patient safety to prevent harms from occurring to patients that we care for. One of the reasons I became interested and involved in quality and safety was a harm that I saw experienced by one of my patients early in my career when I first started as a hospitalist in Toronto over 20 years ago. And one of the patients I admitted came in with upper GI bleed. And amongst the usual care that would be provided, I ordered a blood transfusion for the patient. Later on, I understood and discovered that the patient actually was transfused with blood cross-matched for another patient. So you can imagine the patient then developed acute kidney injury, hemolysis reaction, required ICU admission, and had a prolonged, complicated stay for what would have been a probably 2-day hospitalization for a simple upper GI bleed. And this is just one of many different examples of quality and safety issues that we all face as physicians every day in every setting and every country around the world. And these can be categorized, and some are listed on this slide in terms of adverse events like the incorrect blood transfusion that I just described. Some more infamous examples are when patients who require an amputation but have the wrong limb amputated. And this has actually occurred. Medication errors are extremely common, such as the wrong drug, wrong dose, or wrong concentration. And so some examples would be the wrong concentration of potassium chloride, the wrong dose of insulin being administered. These are things that are happening daily in hospitals around the world. Effectiveness deals with how well we translate the evidence that you've all heard about today into action. For example, we know from the WHO, the World Health Organization, that there are high and unacceptable rates of maternal fetal mortality around the world. Or there are low implementation of evidence-based guidelines for hypertension management, for example, that you'll hear from my colleague and one of the fellow panelists perhaps later. There's also access or decreased access in underserviced areas, unnecessarily long wait times for time-sensitive conditions such as diagnosis of cancer or suspected cancer, or the treatment of ST elevation MI. We routinely measure door-to balloon times as an important quality of measure because we know that time is muscle. And of course, this new area that is being more and more understood around diagnostic errors, that we often, as clinicians, might miss diagnoses or experience delayed diagnoses. But the important thing to remember in quality and safety is that we have a systems approach, and we don't look for individual blame, which used to be things that happened in the past. But we understand these failures occur as a result of failures in the system. And this is so important that there are bodies being recognized and created around the world that deal with quality and safety. So in Canada, we have an institute called the Healthcare Excellence, which helps to promote safety and quality within healthcare institutions. In the UK, there is an improvement arm of the NHS. And in the US, they're well-resourced, so they have the Agency for Healthcare Research and Quality, which often funds research related to interventions and studies that improve quality. And of course, the Institute for Healthcare Improvement, which is the preeminent body for educating and disseminating knowledge around quality improvement methods. And I really like this slide from the population health experts, which really challenges us to think about where is the impact of our work. So as physicians, first and foremost, we deliver clinical care. We care for patients, and that is extremely important. But looking after individual patients, that impact is unique to the individual or the patients that we look after. What drew me to quality improvement, in addition to my experience, is that it has this potential at an organizational level to implement interventions that could benefit not just one patient, but a number of patients in the entire health system. And again, as I mentioned, our health system is far from perfect, and there are really scientific and excellent ways to improve the care in which we deliver. So the second objective is to think about facilitators and barriers. If we're able to understand what helps quality improvement work be successful, then we have a better chance of being successful at improving outcomes. So Heather Kaplan created or published this a number of years ago. It's been probably close to 20 years in BMJ, and it's a schema. It's the MUSIC model for understanding success factors in quality, and it's busy. It's meant to be busy because there's many different factors that can impact the quality of the interventions that are being implemented. But circled in pink at the bottom is physician engagement, and it is an extraordinarily important critical piece that may sink or make your quality improvement work successful. And I'll go through some examples or publications. So the first is a systematic review that was published in 2016 in low and middle income countries, where they sought to understand what were the barriers and enablers of implementing best evidence guidelines to improve obstetrical care practice in these settings. They were able to identify 9 studies that specifically examined barriers and enablers, and they categorized these enablers into high and low intrinsic healthcare professional motivation. And the high intrinsic healthcare motivation would be an enabler, and low intrinsic motivation would be a barrier to quality improvement or implementation strategies. And what do we mean by that? Intrinsic motivation would be internalized within the individual or physician. It would be positive, self-owned, and it helps to promote better task performance and higher competency in the areas of implementing guidelines and implementing evidence-based practice. Extrinsic motivation is the opposite. It would be outside or externally caused. It's lower quality and does not consistently promote positive outcomes. Take another example with antibiotic resistance or antimicrobial stewardship. So again, the World Health Organization has deemed antibiotic resistance as an important area to target for all healthcare jurisdictions because of the emergence of resistance, which is quite challenging. And this systematic review, again, looked at barriers and facilitators of how to best implement interventions that improves antimicrobial stewardship in low and middle income countries. And they were able to include 52 implementation studies, and they used that data and created a map of the relationship between the constructs that they took out of these implementation studies and grouped them into barriers and facilitators of taking up implementation. So this is really important because we've heard a lot about evidence today. And I always say to folks to do that kind of work and research, creating evidence and putting them into guidelines is amazing, but they need to be implemented. And who does the implementing? It's us physicians, and we need to create systems that better implement or allow us to implement the evidence. And again, this construct here in this example with antimicrobial stewardship is that the characteristics of physicians in the bottom right circle, and specifically physician engagement, is once again deemed to be a key facilitator or potentially a barrier if you have disengaged physicians in the appropriate utilization of antimicrobials. And then finally, looking at this one example is a qualitative study where they were able to interview 18 participants in 6 low and middle income countries in terms of what is it that these participants or physicians are telling us in terms of what allows them to better implement knowledge or conduct knowledge translation, as we call it, implementing guidelines. And they were able to list a number of factors. So specifically, the lack of time. So in general, physicians are busy folks, and it could be viewed as extra work to do quality improvement, and that is viewed as a barrier to being engaged. Having the right skills and institutional support to conduct the knowledge translation, and then lacking what we call soft skills, which is really change management, because that is what quality improvement is really about change management. And these soft skills are important to engage others as well as policymakers. And then finally, the continuous engagement that is necessary to do good quality improvement work is viewed as a challenge when there's other competing demands, and there may be also lack of financial or other incentives to conduct knowledge translation. So let's talk a little bit in this vein around how we can appreciate our role as physicians in what we call QI, or quality improvement. And I love this quote from Dr. Paul Podoldan, who is a co-founder of the Institute for Healthcare Improvement in Boston and Professor Emeritus of Pediatrics at Dartmouth Institute. And he says, in healthcare, everyone has two jobs. One is to do their work, and the second is to improve it. And so it's not enough just to look after patients, but we need to think about the system and how we can make the system better and perform at a level that achieves improved outcomes for our groups of patients. And again, just as I mentioned, we have seen and heard and seen published the many, many different barriers to physician engagement and quality improvement. And time, we heard, is one. The lack of experience or knowledge, because quality improvement does require training, can be viewed as another barrier. And then there's also limited understanding of what quality improvement and physician engagement works in different types of settings. Culture is infamously cited as a barrier. We often say culture eats strategy for breakfast. And so we know that we have these unspoken hierarchies in healthcare and certain fixed beliefs about why quality problems exist and how effective our interventions and how motivated our clinicians to do improvement work. Leadership is critical as well, at whether it's the clinical level or the hospital level, as well as supportive resources, and that could be financial, staffing, data, technology, et cetera. And last but not least is the lack of alignment between either policymakers or professional societies, et cetera. But when physician engagement works, it's magic. So this is just a few snapshots of different types of papers, and there are thousands of papers published every year around quality improvement work, and many of them are physician-driven. And these are all examples of how physicians can lead or be part of quality work that improves care at a healthcare system level. So not just your day-to-day care, but for the healthcare system. And residents and trainees have a huge role to play as well. So one example that we did at Sinai, which is where I work in Toronto, is we specifically looked at engaging physicians in patient safety. So we have a reporting system for safety events, but we know that they're mostly entered by nursing staff and don't always represent physician-related safety problems. And what we did was we implemented physician huddle. So much like nursing or nursing staff might huddle every day for 10 minutes to talk about safety problems on their units, physicians are huddling in our hospitals and identifying physician-specific safety concerns. And then they escalate it up and have someone take care of it. In this qualitative study, we interviewed the physicians who participated and said, why did you participate and what did you get out of it? And interestingly, it mapped very well to what is known about intrinsic motivators, meaning that physicians reported they felt valued, they felt they had autonomy, that they could identify specific problems that only they know about. And you all work in whether clinics or hospitals, nobody knows your system better than you, and nobody knows the problems better than you that exist. And so for physicians to feel empowered to say, we had this problem with, the medication error that occurred, and then it gets raised up and dealt with at the systems level, it was hugely empowering. And other ways of aligning or removing the barriers is at a very high level. So we have the Royal College of Physicians and Surgeons in Canada, and they have embedded in the last few years quality improvement as a requirement for all physicians to be accredited and trained through the programs. And that's to say how important quality improvement competencies are in our Canadian setting. Additionally, we have regional colleges, and these are professional colleges that mandate quality improvement must be conducted by physicians, and we have to demonstrate that we are engaged in this work. Additionally, we are very lucky in Canada and the US and other areas where we have access to our own performance data. So prior to about maybe 10 years ago, it was not common for me to know how I'm doing in certain quality indicators. This is my dashboard of 7 different indicators, and I can go and click on one of them. As an example, appropriate red cell transfusions. We know that over transfusion or transfusing to a liberal level can cause more harm than good. And so we define appropriate red cell transfusions as transfusing the percentage of patients, which should be 100%, who had a pre-blood transfusion hemoglobin of 80 or less. And of course, in some populations, it could be even lower than that. And this is from a few years ago, and my performance is gold. I was achieving 85% of the target, but my peers were at 100%. So I had room to improve. And so physician reports and quality indicators are now commonplace and really good drivers of improvement. We're all competitive type A people. We all want to do as well as our peers. So here are a few ways that physicians can participate, and any of you can participate in quality improvement. Or if you're leading quality improvement, these might be some ways that you can engage your colleagues. And so the question is first to ensure that everyone is inquisitive and open to change. And that's really important. Thinking about quality improvement and interventions as you would accept new evidence, new guidelines, etc. And so being open to change. Of course, supporting and championing local quality improvement work that might be happening in your unit, clinic, or hospital is critical. Physicians are viewed as leaders by everyone in healthcare, and whether or not you have a leadership role, you're viewed as a natural leader, and so it's important to champion the work that's happening, even if you're not participating in that work. Folks can think about being an early adopter, so meaning if someone is thinking about trying a new intervention or a new, electronic medical record app or something of that sort, be an early adopter and give feedback. The fourth is being a subject matter expert and or providing your specific feedback. As I mentioned, physicians are uniquely positioned to know the process in which you work and your health system the best, and the best able to provide feedback of what interventions might be effective or not. And of course, getting to the next level, which would be to think about co-leading or collaborating with other folks on quality improvement work, was that we love having collaborators and we work very well in a team. In fact, there's no I in team, and so quality improvement work is done by many individuals, and this would be a really great way for physicians to engage in this kind of work. So I will just end by saying that I hope you will be able to take away, and I hope that I convinced you that quality and safety issues are really important. They impact on patient care and outcomes and is really part of our job as clinicians. Physician engagement is one of the very few key facilitators of improving quality of care. So the power is in your hands in order, if you want to see improvement happen in your system. And finally, if we're able to align intrinsic motivators with quality improvement work, meaning what brings joy to you, what brings joy to physicians, what is fulfilling about your job, then we have a better way of improving the success of the quality improvement work that we do, and ultimately then impact on patient outcomes in a positive way. So I will end with that and invite my next panelist. Thank you.
Thank you, Professor Christine. It's a great pleasure to invite Dr. Padmini Ranasinghe. She'll present on high reliability unit care, quality and safety best practices. And she is the co-director of Hospitalist education programs, assistant professor of medicine, Johns Hopkins physician, Johns Hopkins School of Medicine, Baltimore, USA. Over to you, Dr. Padmini Ranasinghe.
Thank you very much. It's a great pleasure to be here. Third day also, so I'm quite sleepy with the jet lag. So I'm going to focus on my topic is high reliability unit care and a little bit more towards safety side compared to Christine. So she mentioned that landmark report by Institute of Medicine, which showed there are significant deaths happens each year due to preventable medical errors, more than deaths from motor vehicle accidents or breast cancers or AIDS. So this report, when it came out, it really shocked the public, policymakers, healthcare leaders, and then people who are leading patient safety issues. And the cost associated with this also really high. It is estimated that 17 to 29 billion US dollars are due to this preventable adverse deaths. And then later on, actually, they even included malpractice. As you know, US and Canada and those countries have a huge malpractice associated with any harm you do, and it's over $100 billion. And then also, if you just focus on adverse drug events alone, it's 3.5 billion annually for US hospital cost. And the preventable conditions are generally speaking, because I work as a hospitalist, and full disclosure, I just realized, Christine, we knew each other when she was at Hopkins many years ago. Again, we reconnected like a few minutes ago. Anyway, so I'm going to speak this as a clinician who works at Johns Hopkins, my experience in this area. And then primarily speaking, my biggest involvement, in addition to seeing patients in the hospital and teach medical students and residents, with organized medicine, with American Medical Association, with health policy, related to science and public health. So I'm going to just focus on what my experience at Johns Hopkins. And in that report, they mentioned these are healthcare-associated infections that can be prevented. One of the common ones was central line-associated bloodstream infection, CLABSI, and then catheter-associated urinary tract infection, we call it CORTI, and ventilator-associated pneumonia and surgical site infection. Those are the infections, those can be prevented. And then there are other preventable conditions that's happening in the hospital. So medication-related harm, she mentioned. And then the other harms are fall-related injuries, pressure injuries, and DVTs, and then also procedure and surgical-related complications. And then in addition to that, diagnostic and monitoring failures. And then there are three important domains when you talk about errors just happen in the hospital. It's not just because you don't have good clinical knowledge. It's about lack of communication or suboptimal communication, or suboptimal or lack of, or it's almost like teamwork related. And then how reliable the systems are. So those are three important domains when you talk about errors happening in the hospital. So my goal, as I mentioned previously, talk about three key frameworks we have in the hospital. And then there are more than three, but my focus today is for only three. One is called CAS, the other one team steps, and then the high reliability organization is the last one. And if you remember one thing, is CASP is about culture. She also mentioned how culture is important here. And team steps involve a lot of domain, but communication is the primary one. And then the high reliability organization is a kind of about a mindset. How do we think as physicians and then kind of shifting mindset to more like safety, quality in patient care. And then I'll start with high reliability organization in healthcare. So this was first described in aviation and nuclear industry, where there's a risk is quite high and then it's complex. So essentially we are aiming to have low adverse events and errors. Every adverse event in this kind of environment is costly and it's like life-threatening. So it came to healthcare after those the popular report that Institute of Medicine published. And then the core characteristic of this high reliability organizations are, these are principles. I mean, at the end of the day, I think we need to implement, but these principles are important to know. And then when you're creating, even in Sri Lanka, like Sri Lanka specific interventions, and then preoccupation with failure. So we need to be like have a high index of suspicion or looking for like failures where we could improve in patient care. The patient care is like very dynamic, right? So you may find places that where you can improve as a clinician, individual, as a team. And then also reluctant to simply interpretations. What that means is then we sometimes say, oh, this error happens because of one individual or one thing, but we need to think about what is the system actually led to this kind of events. Can we work on system level? And then also next one is leadership is clearly important. We need to buy in from the leadership and also think about like their engagement in creating this high HRO type of organizations and then interventions. And the next one is resilience, right? Like you may have errors or adverse events. How quickly you bounce back? And then how do you make sure like you quickly train the staff and then you back on the track and, you know, continue to work on this resilience and then the safety and quality. And the other thing, I think it's quite important in Sri Lanka too, also deference to expertise. And then some of the decisions, it's like the hierarchical, right? Like the doctor makes all the decision, may not be true. So certain decisions are done by nursing and other staff members. So we need to make sure we delegate the right decision to right person. So not necessarily going through a hierarchical system. And this is the same in a schematic way. Every domain is important when you talk about this high reliability organization. And then I'm moving into, that's a set of principles, right? Like the set of principles is important, your involvement culture, and then the resilience and the involvement of leaders, and then the team related organizational skills. But then how do we implement is one example is called CASP. And then we have, I work at the internal medicine unit at Johns Hopkins. And then in our unit, we have CASP. So CASP, it's called Comprehensive Unit-Based Safety Program. That's the CASP acronym is from that. And this was developed at Johns Hopkins it was early 2000. So what happened was there was a little baby, 18 months old, and the baby came to the hospital with burns. And that got better. However, that kid died because of sedation and dehydration. And that family was quite vocal and advocating for that child. And then there was a lawsuit to Johns Hopkins, and it was heavily costly. And ultimately, the family supported having these safety, quality interventions at Hopkins. Anyway, it was originated at Hopkins and behind the case of this little kid. And the CAS calls for like evidence or science behind this safety, and then importance of communication, as we said many times here, and learning from defects. So you don't overlook the defects and then you just keep on doing the same. How do we learn from that? And then in engagement and leadership. Those are the core principles. And then we do have CASP in our unit. So we have monthly CASP meeting. So these are run and owned by nurses. So that's the key. So there's a CASP coordinator, CASP facilitator, and they have different and really standard roles. And it's preset roles. They know in our unit which one nurse would do as a coordinator, the other one as a facilitator. And there are champions also. I mean, we need to have champions if you need to think about like any intervention that will make it more effective. And then a unit manager, similar to here, like a sister or matron. So you'll have unit manager from nursing standpoint. Provider champion is a physician in general in the hospital setting who's interested and demonstrating some commitment to like, the changes and importance of patient safety. And then next thing is quite important, we also get involved, the senior executives who really need to see and get involved and help actually solving this issue at a higher level. And then generally, I'm just talking about how the CASP meeting works. And then we do have an agenda. and which was set by the nurses. And then generally these are the things discussed. And then what is the culture data we have each month, and then identify and review defects, what type of errors happened recently and what are the near misses and risks. And then also learning from these defects. And it's rather than who did that, it's usually happened why and how this happened, how do we prevent that. And then you create an intervention, you just follow through that. And then it's really important to get the staff concern and frontline input when we talk about these kind of issues. And then previously mentioned leadership engagement. And then we really need to pay attention to ongoing education and training, because there's a high turnover in nursing as well as physicians. So we just need to make sure we have ongoing training in place. And then at the end of the meeting, they have that action items and accountability. That means each individual leave this meeting with their follow-up agenda. And this is one of the examples with the recent CAS meeting. We were talking about catheter-associated urinary tract infections. And these were tracked by auditing the chart. So as I mentioned, catheter-associated urinary tract infection is something preventable. So they look at these variables. Is the indication is correct? And then is there an order from a physician? And then the nurses, are they checking this every shift of the nursing care and perineal care? And then education of the patient. So as you could see, I mean, these are done by nurses by auditing the chart. So documentation is the key, and there's red means the percentage of Foley care by the nursing is low versus perineal care. So these were detected by auditing the chart. And then next thing is really important to mention here. We do have another topic that's been discussed is through HIKE. HIKE is Hospital Epidemiology and Infection Control. And then there's someone from that unit also participate in this CAS meeting. So they talk about hand hygiene. So every time anybody go into a patient room, we have to clean the hands either with hand sanitizer, soap and water. And when they come out, we have to do the same. So there are secret shoppers who are monitoring these things. And then it's not necessarily me as a doctor or the nurses normally may or may not know somebody's watching if I'm doing that. And that's the process of auditing hand hygiene. And then, I mean, they don't do 100%, they like randomly do that and then categorize into different like doctors, nurses, physical therapists, and so on and so forth, and then give a report to each unit. And then also discuss the summary of hospital-acquired infections. And then this is also discussed in this CAS meeting. Additionally, and then discuss what are the areas that we don't do well, and those are the ones in red. And another important area discussed in this CAS meeting is the fall and fall prevention. And then with that, you know, when you come to a hospital and when you lie on the bed for a long time, your mobility will go down. You will have complications related to immobilization. So it's really important early mobilization in the hospital. So that's been measured by a score called AMPAC, Activity Measure for Post-Acute Care, and that's done by nursing. So you monitor those, and it's all documented in the chart, and then you can capture that at the unit level. So at the end of the meeting, so each month you have this meeting, there's a meeting summary involving all this data that we discussed. And then also some action items. And the only thing I didn't mention here is the HCAPs. HCAP is it's a survey sent to the patients after discharge by CMS, Center for Medicare and Medicaid. And the asking patients about the hospital stay, asking about the nursing care, physician care, and so on and so forth. And then the patient will fill out different, like, it's almost giving a number for experience with the doctor, how doctors communicate, whether they were respectful, and so on and so forth. And then the hospital get ranking based on the HCAP score. Some of them are publicly available. Because of that, we really want to do each hospital trying to strive higher level of an HCAP participation and the score. So those will be discussed. And the whole purpose of discussing all these variables to improve. And then at the end of the day, after the CAS meeting, we follow up. And then, whoever's there need to follow through and then implement whatever the discussion happened and then report back during the next meeting. And then with the CASP intervention, it's been shown to reduce CLABSI and by 41%. These are done by over 1,000 ICUs in Michigan area. And then urinary tract infection reduced by 30%. This is non-IC units. And then this also can be used in nursing home setting and then decrease urinary tract infection and additionally surgical site infections. As you could imagine, CAS have been effective in improving safety and also quality. And in addition to, as a bonus, it also improve communication, decrease nursing turnover, and then, of course, increase hand hygiene compliance and improving the IV line insertion checklist, which I'm going to go into next. And then the next thing is the bundle science. And it means it's a set of evidence. It's like few evidence-based practices. And if you actually do this as a collectively and reliably, it should be done all the time when this happens, and it's shown to decrease all the errors that can happen. This is again described by Dr. Peter Pronovost. He was at Johns Hopkins actually when I went there too, and now he's not there. And this is also a result of Johns Hopkins Safety Center called Armstrong Institute, and they did studies on this one. And one thing, this original paper was published related to central line associated bloodstream infection. And then Institute of Healthcare Improvement formalized this, and now it's widely used in worldwide. And what it is so this bundle science is you have set of practices. It's a really simple ones. And then what happens is there's a redundancy. So for example, if you're driving a car, so you have a seat belt, and also if you don't wear the seat belt, at least there's an airbag. So there's some redundancy in these practices in the hospital setting. And then some of the practices that they have for CLABSI or pneumonia prevention or skin infection prevention, those overlap. So you either have a set of rules at the time of insertion, and then also there are similar rule for maintenance and duration. So those overlap. Eventually, if you miss in one area, but you can actually detect in the next level. So those are the reason multiple pathway overlap. And then also it's important to have this behavioral change strategy. And this is simple, and then anybody can understand. This expectation should be very clear. And then also we need to measure those compliance to improve at the goes to the next level. Oh, I think I went. Okay. All right. So when you talk about central line related infections, these are the bundle component, and there's a checklist, and which filled by different people within the team. It's really clearly defined who fills out which, and it is no hand hygiene, maximal sterile precaution, chlorhexidine, and optimal catheter site selection, and daily review of line. So those are the things put into the checklist, and those shown to decrease CLABSI by 66%, and cost saving was 175 million. And then similar to that, ventilator-associated pneumonia, there's a bundle for that, and then those are peptic ulcer disease prophylaxis, deep vein thrombosis, and head of the bed elevation, daily sedation, vacation, so patients can breathe, and oral care with chlorhexidine. So those definitely shown to improve quality and safety and decrease error and improving cost. But the importance is those are done consistently and in a way that everyone understands, and it's quite simple. And then similar to the other two, there's a bundle for surgical site infection that include antibiotic prophylaxis within. When do you do that? Insertion timing and certain hair removal protocols depend on the location of the body. And glycemic control is important for surgical standpoint, and maintenance of temperature. So those also shown to improve reduction in infection in hospital setting. And again, I want to highlight how important this is not optional or ad hoc. When this happens, if you're really looking for like a sustained safety standards, those has to be clear and should be standardized framework. I mean, it's like a checklist, right? And teams exactly know what to do and every time. And there's a reduce in variation in care, and then makes a complex process very simple, memorable, and reproducible. Then moving into team steps, and I know she mentioned about the HRQ. So in the US, HRQ plays a huge role in safety and quality in regards to funding and doing research. And then also this is part of Department of Defense. They have this thing called team steps. This is almost like providing a practical training checklists and tools to make communication. This is purely communication. As we mentioned previously, communication is clearly important in prevention of these errors and improving quality. And communication should be predictable, clear, and reliable. So to improve patient outcome and staff morale, so you need to create that safety culture so that it's not a blaming someone. So team steps involve the structure, again, leadership, and monitoring of different situations, and then you definitely need to have that mutual support and communication tools. And then if you implement this team step in the hospital setting, there's a 50% reduction in preventable events and improved communication scores and enhanced safety culture. And there's an acronym for, like, if you want to create a standardized communication for every team member in the hospital, it's called SBAR. You need to, we'll say if a nurse call a doctor, they need to use SBAR. So you need to identify the situation. You say patient in room 32 and with this condition, and the background is patient has a history of, we'll say, hypertension, came with pneumonia. And then you tell the assessment at the time, now the fever is this and the blood pressure goes down. And the nurse's recommendation is either doctor needs to see the patient or say, oh, I'm worried about infection or something like that. You have this SBAR. The nurses actually learn that when they in the nursing school, as well as when they get in service training in the hospital and in education setting throughout the nursing school, and then after that. So it's important that you have a uniform way of communicating so that like errors will become less. And then also it will help to prevent critical information getting missed. And then also, additionally, we need to make sure we have a shared mental model across doctors, nurses, and staff. And then regardless of the rank, so we just need to make sure we empower the team members so they speak up, and then ultimately it's good for the patients, and then also in general for the hospital or the healthcare systems. And actually it's been used in over 3,000 healthcare organizations worldwide, and then it definitely has improved communication-related adverse events. And then, as previously mentioned, so it is important we go from blame to learning. So, it used to be like, okay, if somebody make a mistake in the hospital setting, and you the shame or blame, rather than that, you make sure this is a learning opportunity. And then it's more than like which step in the, if you make a mistake, you say which step can be improved or prevented further. That might be the question rather than blaming. And I think I have very little bit time, so I'm talking about the electronic medical record, how it is important. I think I did talk about in different setting yesterday. So electronic medical record has shown to be really beneficial because you have all the data and you have the dashboard and in each patient in the hospital. So you can capture some of the information so that capture early to prevent certain mistakes or but identifying certain condition early so that prevent complications. And then also we have smart monitoring, and then very important medication error prevention, closed loop medication system we use in the hospital setting. So that's really important. And also we have a team communication platforms embedded in the electronic medical records. I'm going to move a little fast to finish. I think my time is up. I have like a couple of more slides. Let me see. Okay, so this is probably one of the last slides. So we have a system at Hopkins called HERO, Hopkins Event Reporting Online. Anybody in healthcare teams can report anything they feel like would have been prevented, or they are concerned about, or they feel like, okay, there's some error in their mind. You can report anonymously, or you can put your name, and this goes to a risk management team, and they can do a root cause analysis. And then give feedback at an individual level, and then essentially it's rather than blaming, they figure out what is the system changes needs to happen. So this is a good tool for somebody who doesn't want to speak up when there's a problem like that. And then lastly, I would say it's important that when you create an intervention to monitor and follow through that. That's really important. That doesn't matter what tool you use, you just need to follow through, and you need to make sure you do have a method of evaluating them, and then iteration as you needed. And this is my last slide. So Don Berwick, he's kind of considered as an expert in safety, said every system is perfectly designed to get the results it gets. If we want a safer care, we must design safer system. So, and also safety is not about having more resources, it's about using what we have wisely, reliably, and together. So thank you very much.
Thank you very much, Dr. Padmini Ranasinghe, for your excellent lecture. Our next speaker is Dr. Upuli Wijemanne. She will speak on quality and safe healthcare delivery, Ministry of Health experience. Over to you, Dr. Wijemanne.
At the outset, I would like to thank the President, Ceylon College of Physicians, and the organizing committee for giving us this opportunity to share the Ministry of Health experience related to quality and safe healthcare delivery. First of all, this is to declare that I do not have any conflict of interest. So this is the outline of the presentation. First, I'll be talking about the evolution of healthcare quality and safety in Sri Lanka, safety initiatives, challenges we continue to face, and way forward. In addition to the national program, many advancements in patient safety were initiated at the institutional level, often driven by the leadership of heads of the institutions. So certain initiatives were also introduced by the professional colleges, contributing to the larger, broader patient safety agenda. Furthermore, Sri Lanka has witnessed remarkable achievements in maternal and child health, largely facilitated by the Family Health Bureau. However, I'll not be talking on those. I'll be only focusing on these 4 areas. So how did the National Quality Assurance Program begin in Sri Lanka? All began way back in 1980s. It was relaunched in the year 2000 with the concept quality healthcare through productivity. Here, the excellent performance was seen at the Casa Street Hospital for Women, which is a highly specialized maternity hospital under a unique leadership. During the period, this particular hospital was identified as the focal point, and the National Quality Assurance Program ran from there. However, in the year 2012, the Directorate of Healthcare Quality Safety was established, and in the year 2024, another important milestone was that transforming this directorate as the Patient Safety and Accreditation Bureau with 5 subunits. That includes patient safety, quality, accreditation, clinical governance, monitoring, and evaluation. This is a governance framework, and this is a very, very well-structured framework. The National Steering Committee, previously the regulatory body, has now been renamed as the National Healthcare Accreditation Council, and that serves as the advisory body. The former Directorate, now as the Patient Safety and Accreditation Bureau, coordinates the national quality safety initiatives in the country. At the institutional level, every hospital has a quality management unit staffed with a medical officer and a nursing officer. They are responsible for implementing and monitoring institutional quality assurance activities. Work improvement teams at the ward level, they facilitate the activity from the grassroots level. This structure supports a strong interconnected network from the national to ward level that ensures quality and patient safety initiatives are consistently implemented, monitored, and sustained in hospitals. These are the two national documents providing guidance and sets the overarching framework for activities related to quality and safety in Sri Lanka. These are the National Policy on Healthcare Quality Safety and National Strategic Plan. During next few slides, I'll be discussing on the several safety initiatives implemented in hospitals to prevent common sources of patient harm. Firstly, let me begin with medication safety initiatives. National Action Plan on Medication Safety structured around 4 domains introduced by the WHO. Several safety initiatives are being implemented in line with this plan. One is the assigning of a liaison pharmacist in hospitals to assist in activities related to medication safety, the aim of preventing medication errors. To further strengthen these efforts, medication subcommittee was formed under the chairmanship of Director General of Health Services. In this high-level forum, to make key decisions to enhance medication safety practices across hospitals. Another common issue is prescribing errors. A circular was issued with clear instructions that every prescription must include the name and SLMC registration number of the responsible consultant, emphasizing the importance of generic prescribing. Another initiative was the introduction of proper labeling of medications during dispensing. Sample labels for 62 medications in Sinhala, Tamil, and English with pictorial instructions indicating the correct time of taking the medication were introduced. Further, national circulars were also introduced for ham drugs, LASA drugs, and along with the guidance documents. All hospitals are instructed to implement these as part of strengthening safe medication practices in the country. This is a practice package for medication safety, which is now at the verge of finalization. Medicine list and guidance documents for LASA drugs, ham drugs, and even for error-prone abbreviation medications were included in this package. Then dispensing labels in local languages, introduction of patient information leaflets, safe practices in polypharmacy, medication reconciliation, reporting of medication incidents are those elements in the package. Even before initiation of these elements, some of them have already been implemented in certain hospitals with discretion. However, plans are underway to extend this package to all the government hospitals in the country, aiming to strengthen national medication safety practices. Next is on IPC, that is Infection Prevention and Control. This is the overall IPC structure in Sri Lanka, both at the institutional and hospital level. The Bureau serves as the national focal point for IPC. A structured IPC program is in place for more than 2 decades in hospitals with a dedicated IPC team, which includes ICNOs, medical officers, liaison nurses at the ward level. The teams are led by a consultant microbiologist, and they provide overall planning, technical guidance, and monitoring, ensuring effective coordination of IPC activities in the country. Ministry of Health has established a high-level IPC subcommittees to strengthen IPC practices. And also we are at the finalization stage of IPC policy. An IPC manual developed by the Sri Lanka College of Microbiologists has served as a primary guide for most IPC practices in the country. So, Thank you. Surgical safety checklist was implemented at the national level in 2013 and the consent form in 21, representing significant milestones in standardizing safe surgical practices. Nevertheless, prior to these national directives at the institutional level, some surgeons had independently developed and utilized consent forms to obtain informed consent from patients. That highlights the long-standing ethical and clinical importance placed by the surgical practice in Sri Lanka. An important activity to strengthen diagnostic safety in hospitals is the replacement of old versions of bedhead tickets and diagnosis cards after 60 years with more structured formats and guidelines. This encourages appropriate documentation and evidence-based practices, ensuring correct and timely diagnosis. The patient observation chart and early warning score was introduced, enabling healthcare staff to recognize early signs of patient deterioration and to respond promptly. These are the incident reporting forms and medication incident reporting forms and analysis forms introduced to government hospitals. Learning from incidents is vital, and during their overseas training, all physicians must have engaged in such activities. An official website and a public help desk were launched for patients and families to see the availability of clinic services in each institution before they visit. The first steering committee for the patient safety network was formed with the involvement of patient groups together with the Ministry of Health officials. This ensured that patients themselves have a voice in shaping and strengthening safety initiatives in our healthcare system. The ultimate goal is to establish a strong system of clinical governance across the country. Clinical governance is not just a framework, but also a culture and a set of systems that should start from the ward level that ensure continuous improvement in healthcare. To achieve this, a national training program has been already commenced, and the strategy is to develop a pool of master trainers who will take the responsibility of different pillars of the governance framework. Capacity building is a key component in fostering culture of quality and safety. The Manual of Master Trainers, first developed in 2015, guided the initial training module, and then the new CPD manual now complements this effort. Master trainers were selected from hospitals, and in addition to this, a diploma course in quality and safety were introduced in collaboration with the University of Colombo, extending training opportunities even to private candidates. In 2019 to 24, hospitals were recognized with bronze, silver, and gold awards on the World Patient Safety Day for best practices. So, over the years, many institutions have adopted sustainable strategies to promote safety practices, contributing to stronger safety culture in hospitals. To further strengthen the safety culture, we collaborated with many stakeholders, including professional colleges, and also had the opportunity to share our experiences with international delegates with both local forums and global platforms. In 2013, we commenced the performance review mechanisms, and this was conducted periodically to monitor the quality initiatives implemented by hospitals. Now we have introduced a digitalized software called QPIT, that is called Quality Performance Evaluation Tool. The aim is to receive accurate, timely information from hospitals for decision making. Supervisory visits are also carried out to closely observe what is the performances in the hospitals, and a monitoring tool for primary medical care institutions are also introduced, and the two bulletins are developed to report the activities we have carried out up to now. Let me brief you the latest initiative of the Bureau. That is the Hospital Accreditation Project, which will be implemented in a phased manner. Accreditation is implementing healthcare organizations' compliance with pre-established performance standards. This will benefit patients, staff, and it adds value to the health system. The roadmap for accreditation was finalized after having had several discussions with stakeholders, and the activities are funded by the Global Fund. And to maximize the use of this grant, it was decided to commence 4 simultaneous activities, and those will be detailed in the later slides. The first was drafting accreditation framework by the Bureau. It has 4 components. Component 1 is ensuring delivery of safe care for patients. Then improving systems complementing the delivery of safe care. Third, ensuring safe hospital equipment, facility and environment. Fourthly, organization, governance and management. Under component 1, the subcomponent 1.7 is safe surgery and anesthesia. And this example is being described in the next slide. Second activity was the development of quick reference guidance documents for accreditation purpose. For this, the Bureau worked closely with the professional colleges and the National Guideline Committee. This is to develop standards along with the local consultant. Now we have the guidance documents and we have the framework. What is our next is to develop standards. Here you could see an example how the standards should be developed based on the available guidance documents. The fourth activity is survey training. Currently, procurement process is underway to recruit an international organization, and the surveys will be selected from clinicians, hospital directors, and nurses. They will be trained to assess the level of implementation of accreditation standards in a hospital, and the proposed structure for evaluating the accreditation program is built around 5 stages, as you see here. Each stage reflects the level of implementation achieved by a hospital. Based on this structure, hospitals can be categorized according to the stage they belong to. The key challenges are limited exposure of medical students, as quality and patient safety concepts are not adequately introduced at the undergraduate level. There's no uniformity in applying certain practices across institutions. Therefore, some initiatives struggle with long-term sustainability. Gaps exist in monitoring mechanism because we have not prepared monitoring plan along with the initial plan itself. In hospitals, limited involvement of doctors, that is medical leaders, due to their busy schedule with clinical work are a few challenges I could mention. The way forward is, as we have already commenced establishing an accreditation system in a phased manner, commencing from teaching hospitals, we have planned to expand that to other care levels as well. Another important activity is the revision of both National Strategic Plan for Quality and Safety and Medication Safety for next 5 years, from 26 to 30, and development of IPC Strategic Plan and Guidelines once IPC policy is finalized, and strengthening incident reporting mechanism, including medication safety, is also a dire need in our system. And continuation of close monitoring of performances through software tool we have prepared. So the key message is quality in healthcare is not a destination, but a continuous journey of learning, commitment, and improvement. So let us work together for quality and safe healthcare delivery, ensuring no harm in our institutions. I would like to acknowledge all the leaders who led the program and those officials who guided from the Ministry of Health, and the professional colleges who collaborated with the Directorate for these achievements. And also I extend my sincere thanks to the President and the Council and the Organizing Committee for the invitation. And thank you very much. And we look forward for continued collaboration with professional colleges. Thank you.
Thank you, Dr. Upuli Wijemanne, for your wonderful presentation. And it's time for panel discussion. So for the panel discussion, I'd like to invite 3 panelists. Dr. Gaya Katulanda, Consultant Chemical Pathologist, National Hospital of Sri Lanka, Colombo. Dr. Vindya Kumarapeli, Director Policy Analysis and Development, Ministry of Health, Sri Lanka. And Professor Chathurie Suraweera, Professor in Psychiatry, Head Department of Psychiatry, Faculty of Medicine, Colombo, Honorary Consultant Psychiatrist, National Hospital, Sri Lanka. So I invite all 3 panelists here. I can start.
Thank you. We have now 25 minutes for discussion. Extra 10 minutes. That's good. So now it's open for questioning.
Or shall I start the discussion?
No.
Now, all our both the international experts and Upuli Wijemanne spoke about culture on patient safety. So I'll start with Dr. Vindya Kumarapeli. She's very busy with preparing this health policy for 2026-2035. So, what is your way forward in the policy document to improve the patient safety culture in the organizations and for our both clinicians? I would say how you see as a clinicians to improve the patient safety culture, because now I saw one of this presentation, this diagnostic errors. So it's difficult for as founder director of healthcare quality and safety. When we introduced this adverse event form in 2016, when I left in 2017, for 1 year, it was only about 2,300 odd adverse events were reported throughout the country. It's very less. Okay, so there should be a culture to be developed to improve the reporting mechanism. So over to you, Dr. Vindya.
Before she answers, I want to add another question to the same thing. Now, these safety issues, the first speaker highlighted, and then Dr. Wijemanne's lectures, safety did not come to that extent, I suppose. Now this safety came, but one of the reasons for lack of safety is the wrong identification. That part was not right. So now we have problems in medical wards, especially casualty rates in medical wards. Now, a large number of patients are admitted within few hours. In my hospital, Colombo National Hospital, from 10 p.m. to 6 p.m., around 100 patients are admitted for that hours. And in few hours, the bed capacity is overrun and patients are everywhere. So there is no proper identification process because some patients have the same name. Their full name is not written. There are these common names are there. So there are many patients with the same name. So there are instances I have come across, ECGs were taken in wrong patients because what happens was the ECG technicians come around 1 o'clock or 2 o'clock in the morning and they call, people are sleeping everywhere. Now all of them in casualty wards don't have beds. They're everywhere. Some are on the floor, some they have to find out. And the nurse called by the name. Those who can hear the name will come, otherwise the other patient will not come. So the blood was drawn from the wrong patients for investigations. ECGs are done on wrong patients. There's the lack of identification of patients is a problem. Especially the casualty wards. Once they go to the common ward, then of course there are bed numbers and that is better, but casualty wards is a real problem. So has the ministry taken any action or anything to prevent that type of thing? There is a second question added to you.
Thank you very much. Thank you for the question. So in terms of the national health policy, the upcoming 10-year health policy, so the existing policy would end this year. So Ministry of Health is in the process of developing the next 10-year health and well-being policy till 2025. So in that process, we did a situation analysis and there we identified patient safety as a major component under the pillar of governance. As I think it was mentioned by the speakers also, even Upuli mentioned, it actually comes under governance. So quality of care is a subcomponent in the governance pillar. So what then based on the series of policy discussions that we have conducted so far, what we propose to recommend is that actually the policy is not being finalized. It's at the stage of drafting policy statements. I can share to answer both questions, what we propose in the upcoming policy, and based on what Dr. Upuli presented, one major proposal and actually one major gap is issues with digitalization, digital health records, and we heard from Canada and USA to the level that they have done digitalization. So one option that we are proposing in terms of improving quality and safety is introduction of the National Electronic Health Record. It's not just the initiative of the ministry, it's a government initiative. And in the planning section, actually there's a information directorate. They have developed a national health blueprint. So that would be the key to all these problems, number one. Then second one is Dr. Upuli mentioned very clearly standard care packages. So if we really want to ensure quality of care, in our country, we have 3 levels of care provision: primary, secondary, and tertiary. Then we should not forget the private sector. If you take the private sector, of course, inward contribution is very low, maybe maximum 10% according to the recent data. But if you take OPD care, it can be up to 60%. So the second point that we are proposing in the National Health Policy is the standard care packages for the 3 levels of care. With that only we can think of accreditation or any clinical audits. So third one, I think it came in all the discussions that we are proposing is transforming our health workforce to achieve such outcomes. It's one of the main pillars in the upcoming health policy, how to transform the health workforce. Of course, it's to achieve universal healthcare, primary healthcare, at the same time to achieve quality care. Then accreditation, Upuli mentioned the proposals coming from the government, even in the National Health Policy. Of course, actually we had a policy dialogue including the private sector. So maybe the private sector, large hospitals, they do have their own accreditation methods. They are mostly international, well recognized. But what about the other hospitals? And also, as I said earlier, the private small nursing homes, and most of our clinicians practice after hours care. We have dual practice allowed in our country. There are private practices also. If you really want to improve patient care and quality, the fourth one that we are proposing in the policy is actually to make sure that the private sector is also regulated. So just to recall some of the initiatives in the upcoming policy, I can talk a lot more, but I'll give the mic.
And we'll give the clinicians.
My question, the identification, how to improve, because it doesn't cost anything extra. Available resources are enough. Only the method has to be, some method has to be invented.
Yeah. So thanks for the question. Now, I was just talking about the national initiatives only, but as I mentioned in that, I have mentioned we used to conduct capacity building training programs every year, about 6 programs participating by different institutions in the country. So we will be teaching them how to recognize, how to improve the systems, like introducing a label or maybe to identify the patients correctly. Not only that, even there are other 5 goals, 6 international safety goals according to the JCI Joint Commission International Suggestions. So that way we used to ask the work improvement teams, the hospital nurses, doctors, quality management unit doctors to develop all these. So those are not introduced nationally, but we have trained them how to do it in the respective hospitals.
Yeah, for now, this just asking and this thing will not be enough. Because in my case, from 10 o'clock to 5 a.m., they come in a queue, one by one. And then they, when they come after midnight, all the beds are occupied. So they sit somewhere on the corridor or sleep under a bed or somewhere. So there's no way of just identifying them. So informing the staff is not enough. There should be a method some label, something has to be done too, because they come with the same name.
Yes, like we have introduced the labeling method also, but the thing is you're referring to the biggest hospital in the country, the national hospital, but in other smaller hospitals, they are doing it. That is the responsibility of the quality management unit, medical officer and nursing officer. As I mentioned in the governance framework, that is the grassroots level. They should look into the respective institutional implementation. So we will be governing that from the central level, because we will be conducting performance review mechanisms where they come and present their performances. So that's how we do.
Yeah, it should be a local thing, I suppose.
And our clinicians.
Yes. No, the thing is about that identification thing. I think when it comes to a bigger hospitals like National Hospital, digitalization is the only way to improve identification. Okay, then.
I think, forget that I'm a psychiatrist. I'm coming here as a quality who is interested in quality assurance. When it comes to quality assurance, it's there as a huge chunk in all the postgraduate programs, undergraduate programs, and all the degree programs. Like, let's say, if you take occupational therapy, physiotherapy, and even the technical courses. But that is only known by the coordinators and the people who handle it. As Dr. Upuli correctly mentioned, like the undergraduates are not aware or not being sensitized to the quality assurance processes, as well as they are not aware of the things that are in place to ensure the quality. It's the same with physiotherapy, occupational therapists, and the laboratory technicians, and so on. And if they are not aware of something that is being put forward to assure the quality as a part of quality assurance, they take it as a pain in the neck. So that is very important that we take forwards that this new drug chart is being implemented, because these faults have been found in the previous prescription errors and so on. And this diagnosis card is being implemented as a new thing, because we are usually resistant to new things. So that we need to get, so yes, we need to introduce the concept of quality assurance, which is there hidden, and there are processes which are being taken forwards, but other than the people who are involved and coordinating and implementing it, the rest of us do not know that. So that's the first thing that we need to do, because even in patient safety, that there are certain things. Now we have done this drug list and the new drug charts, but that being implemented because of these errors to make your lives easy and to sort of streamline it, that message also should go. So that will contribute tremendously, so that the people will be flexible and would grasp it.
Now you said about the undergraduates, so I want to add to that. Now, since Professor Pedarshan Kalappathi is in the audience, now these undergraduates will come as intern house officers to us. I think in the curriculum, undergraduate, in even the postgraduate, nothing is taught about the health economics. Absolutely nothing. They don't know the cost of the drugs. They treat drug which is 5 rupees and drug which is 50,000 rupees at the same level. So at least there is immunoglobulin or these things, they have no idea what the cost is. So at least some part will be important when they practice. Want to comment on that, Priyadarshan?
Thank you very much. I think it's a very valid point that you have made, Pradeep. So it's not only actually about the cost of medicines, but the very fact that even what Chathurie brought up, I think in all undergraduate curricula, we need to highlight the need for patient safety, which is a very big thing in now the developed countries. I have been working at the WHO Patient Safety and Quality of Care unit earlier on. So, and there Lanka also, as well as in many of the, I think both the speakers from Canada and US, Padmini, you highlighted, it's a very, very important aspect in undergraduate medical education. And in fact, undergraduates, before they start clinical practice, they have to complete patient safety modules, which is a compulsory thing, and that certificate has to be, submitted in their portfolios. Without that, they will not be able to go to hospital placements. So I think we need to include, make sure we have actually from our Pharmacology Association, we have gone through medication safety curriculum, because I was involved in the WHO and the WHO medication safety curriculum. We have actually taken steps to done a survey about what aspects are included into the curricula in our medical faculties, and we have included requested all faculties, the departments, to include medication safety aspects into the curricula, which was actually not there earlier. So I think even writing prescriptions, look-alike, sound-alike medication errors, high alert medicines, those were actually not addressed adequately earlier. All, even transitions of care, polypharmacy, all that. And one other aspect is actually, because for a country like ours, which is recovering from economic crisis, the cost of medicines. I think there were initiatives earlier to indicate the amount of money that is spent on these medicines, to give that information to patients, but I think there were some, resistance to giving that, because that might indicate that patients have to pay that amount and so on. So I think that initiative was not implemented through the ministry. But we, of course, during teaching, we always, try to highlight the fact that you need to understand, even though the ministry is paying for that, it is actually, it is coming from everybody's, taxpayers, or, the ministry is paying for that, although patient may not be paying for that particular medicine. We have actually, from the Pharmacology College, we have identified the most costly medicines on which the government is spending money. We have identified tenecteplase, intravenous immunoglobulin, IV albumin, and factor VIII as the four most costly medicines that we are spending money on. And we have developed guidelines on the usage of these, because we find sometimes IV albumin is used without adequate indications, and even IV immunoglobulins. So we have developed those guidelines, and we have actually planning to submit to the Ministry of Health to issue a circular. It's almost finalized. So those are some of the activities that we have initiated to ensure patient safety as well as cost-effective prescribing. Thank you.
Thank you, Professor Priyadarshini Galapati, and now it's open for our audience to ask for your comments and the clarifications. Yes.
I mean, listening to this conversation and reflection on the culture, right? I know Sri Lankan culture and the US culture in regards to healthcare. How do we improve this team dynamic here, right? I mean, this is a little bit hierarchical system here. So we are to start that we work as a team in a way so that everyone has a say in regards to patient care, because that's what at the end of the day important. So that's something I think medical education start there, and then it just move up. And then I know you asked about the medication. It's not only that, it's like a complicated, several things are connected, right? If you start with one, probably you can think about the other, or maybe apply that to other areas in safety quality. And then lastly, I would say, I think digitalization or EMR is quite important, but at the same time, the importance is like in the US struggle so far is it was a burden. When they first implemented and the first physician burnout increased, because some of the interoperability is not good, and then it's another burden. So I think Sri Lanka and other countries have the luxury learning from those systems, and then also having this universal system to implement it properly. And then lastly, I would say, if not doctors, now patients might demand that, given the environment that we are living in with technology. They see like the malpractice, medical legal cases, especially this younger generation. So I think in some ways, like, doctors should own and lead this, or the medical education in every level.
So just to add on the reflection, what I've heard is incredible, the amount of work that's been done in this country in such a short period of time. You should be very proud of the work that you're doing here. What you've done is taken decades of work in other countries and done it over such a short period. And yes, there's always work to be done, which is great because it gives people like us a job. But it's actually just unbelievable what you've done. And we would love to learn what works in this setting to share it with others as well. So congratulations.
Before we wind up, this certificates has to be awarded to the 3 speakers. I invite Dr. Sridharan to Professor Christine Soong, Dr. Padmini Ranasinghe, and Dr. Upuli Wijemanne. Yeah, and the panelists. You can.
Could I now please invite Dr. Lilanti Subasinghe to award certificates and letters of appreciation to our chairpersons.